your review. So today's focus, as mentioned, will be related to all things QPP, with some brief recap to get us all up to speed on the final overview. And today's presenter of the QPP ruling will be Aaron Higgins, who's been with SHP for a few years now in our analytics department, and with 12 years experience with federal quality programs and various private practices, focused primarily on quality programs, QPP in particular. He's done a couple of these in the past very successfully, and as you see with our topics today, Aaron, I'll hand it off to you.
Alrighty, thank you, Jason. Okay, so let's talk about the final rule. As you know, this is a annual affair. The final rules are never quite final. They change annually. And over the summer, we got our proposed rule. And then in November, if you haven't had a chance to read it, in November, CMS did release their final rule. So let's dive right in. So let's first talk about some of the tweaks and changes. These are just kind of some high-level stuff, didn't really fit into any particular category. So the biggest, well, on this page at least, the biggest change is the new MIPS eligible clinicians. And that is the clinical social workers and the certified nurse midwives. What's kind of interesting about this is CMS continues to add more and more clinicians to the MIPS eligible clinicians list, and then they find new creative ways to exempt those clinicians from the list. So it is one of those odd behaviors that CMS has. Hey, more people are participating, but even more opportunity to get exempted from it. And we'll talk about those exemptions here shortly. Another change is that the CMS web interface, which I think nobody here on the call is using, it's usually for large organizations such as ACOs or large healthcare organizations that are participating in MIPS. They're actually going to sunset it this year. Well, last year, 2020, they were going to sunset it. And then they said, oh, okay, we'll extend it through 2021. Well, they're extending it even further to 2024. And this is just another submission method. Some measures are specifically attached to the CMS web interface. They are looking to make some changes to those in future years, so they gave themselves a little bit of extra time. In the proposed rule, CMS did say that they were afraid that the 2020 data was not going to be complete enough due to COVID. What CMS means by that is they compare performance and metrics year over year to the previous year. So the 2021 data will actually be compared against the 2020 data. So that was a bit of a surprise. CMS had said that they were most likely going to get compared against 2019 because that was going to be more complete, but they felt that they had enough completedness to extrapolate out performance. So that actually might be a good thing for those in 2021, particularly those that might have more niche measures to be compared against a more a less broad data set. Then there is a change coming to the data completedness for 2020. Sorry, for 2022. The data completedness bumps up to 70%. Currently, it is set to 60% and will then be ramped up in 2023 to 80%. Another change is the complex patient bonus. This is a big one, particularly for those who have complex patients. The complex patient bonus is worth 10 points of your total score. So if your total score is 88 and you have enough complex patients, your score will get bumped up to 89. So this is a pretty significant change with the scoring, particularly if you really lean heavily on this. And a lot of the specialty groups do lean heavily on the complex patient bonus to get them up there. The bad news is it's going to go away, or at least how we know it. So it's going to remain for this year, 2021, but in 2022, it's going to be limited to clinicians that have a median or higher value for at least one of the two high-risk indicators, which is the HCC score. So those that are properly coding their patients. So, a patient who has diabetes and hypertension and maybe macular degeneration, if you are properly coding that with your encounters, that's going to increase the patient's HCC score. So this is really important for those that lean on having complex patients to make sure they're properly coding their patients. So they're going to update the formula to standardize the distribution of 2 risk indicators so that the policy can instead target clinicians who have a higher share of medically complex patients. So they know that specialists really lean on this complex patient bonus. And so now you really kind of have to prove it. They're more or less taking this away from the PCPs, those that are just dealing with the runny noses, the less medically complex patient. It will permanently be set, though, to 10 points. So it's not going away. It's just going away in its current form and is going to evolve into requiring a higher HCC score. If you're not sure what I'm talking about when I'm talking about an HCC score, reach out to me. We can talk about it. It's far too complex to really go into this conversation. Okay, so speaking of scoring changes, let's get right into that. As you know, MACRA was signed into law in 2015, and it was written in a way that will require certain thresholds within MIPS to happen at certain times. In this case, by 2022, CMS is required by MACRA to set the category weights to what you see here, 30% for both quality and cost. Promoting interoperability should be set to 25, and improvement activities set to 15%. Furthermore, as required by MACRA, the mean final score from 2017 is to be used to determine what the minimum score must be to avoid a penalty. This is therefore the biggest jump that we have seen in the minimum score so far. For 2021, that minimum score is 60 to avoid a penalty. That's moving to 75 for 2022. That's a 15-point move. And this is set by law. So CMS doesn't have any movement on this. They have to do it. The law said that CMS could pick the year of the lowest mean score, but that they had to set it by 2022. And in the case of 2017, that was the lowest mean score. And CMS said, sorry, that's just the way it's going to be. What is interesting, though, is the exceptional performance. That was going to retire in this year. This was going to be the last year for exceptional performance. They are reintroducing it, except now the threshold for that will be a score of 89. So if you score 89 or higher, you'll be classified as an exceptional performer. And this will be the final year for real this time, at least according to this final rule. It could always change, where you can get the extra incentive payment. And then finally, CMS has confirmed their intent, and we're going to get into this in a little greater detail, their intent to automatically reweight the promoting interoperability for small practices and now allow for exemption from the cost category for small practices. So the exemption for cost category is kind of new. It did exist before, but they're clarifying that. But then they're doing an automatic reweighting, and we'll get into that here in a second. But what is a small practice? A small practice is a 10 or a virtual group that has 15 or fewer eligible clinicians. I think most of you on the call today probably qualify for this. So we'll get into it here in a minute on what that means for you. So I'm a pretty visual guy. I like being able to see how this pie chart is split up. So the weights for 2021 compared to 2022, you can see they took away from quality 10% and gave that to cost. They kept promoting interoperability and improvement activities the same. Okay, so per MACRA, MIPS must remain budget neutral. The losers, those that are penalized, must pay the winners. And so the more penalties there are, the larger the incentive percentage is going to be. Whereas the fewer the penalties, the smaller the incentive payment. And some people have said, well, I was promised 10% because I did so well. I scored 100 points or 99.99 points. Where's my 10%? Well, sorry, Charlie, you're not going to get it. It's really tough to get that if everybody's doing really well. Well, macro says this has to be budget neutral, and the losers pay the winners. And so if there's not as many losers, then the winner's pie is going to be smaller. So that being said, 2022 is going to be a little bit more interesting because it is a higher score required, 75 points. I actually think we're going to see a fair number of those falling into the penalty window. It's going to be a lot harder for them. So let's talk about that auto reweighting. This is a big one, guys. It really is. So promoting interoperability, which lived its former life as meaningful use, if you recall, this is really geared around towards using EHRs to communicate with patients, and things like sharing records electronically, patient portal use, all sorts of the electronic reconciliation, medication reconciliation, all of those measures that fall into promoting interoperability. Well, CMS has said that they have noticed that a vast majority of what they consider small clinics are turning in garbage scores for PI. They're either missing it entirely or they're missing most of it. In fact, they said that was something like 60% of small clinics were just utterly demolishing in a bad way their PI scores. And so they said they needed to do something to stop the hemorrhaging, to give time to these smaller practices to really get their arms around PI. What are and for CMS to understand what are the barriers to these small clinics from successfully reporting PI. And so automatically for 2022, they will reweight PI to 0, meaning that it will, and I'll show you a visual representation, it will eliminate promoting interoperability from a required category to report automatically for any clinician in a practice with 15 or fewer. So if you have 15 clinicians, perfect. You're automatically getting scored to 0. Now, here's the thing. CMS has said that this automatic reweight may only last for a few years. So don't get used to it. And I would argue don't fall for it. If you are already successfully reporting, promoting interoperability, and you have no issues whatsoever with your score in PI, and you're firing on all cylinders there, that's not a problem for your organization, don't take it. Go ahead and submit your promoting interoperability. The reason why I say that is in a couple of years when CMS says, okay, well, small practices are no longer being reweighted, you don't want to have to have turned everything off and gotten out of practice of doing these measures. They are coming back. I submitted a comment specifically on that CMS is kind of walking a fine line in regards to some practices may see this as a cost savings opportunity that they can turn off interfaces or they can stop issuing patient portals, and they agreed with the sentiment of that, and they are going to be ramping up their communication about promoting interoperability, that those that have successfully submitted and continue to successfully submit that are small practices should just continue to do so. This is only really for those practices that have struggled historically with their PI. Okay, I'll get off my soapbox. Now let's talk about cost category. CMS has made being a small practice a reason to apply for exclusion. This one's not automatic. If you're a small practice, again, 15 or fewer clinicians, you can apply to be exempted or excluded from the cost category. The cost category, if you have some questions about that, are automatically scored and submitted measures based off of your claims data. And some of this could be data that comes from a patient who is seen in the hospital, but they're your patient because you have seen them, and their costs can be associated with you. So smaller clinics that have less control and less insight into their costs, well, guess what? You can apply for a cost category. So take a look at your past scores. See how well you did score on the cost category. I can say that it's probably okay. I would encourage you, if you have done poorly on your cost category in the past, to go ahead and apply for that exclusion and give you time to focus on some of the other areas within your organization, or maybe look at what sort of insights and tools, such as a population health tool, that can get you that insight that's necessary to improve your cost category score. So let's look at what that looks like. So if you were to take the automatic reweight with the promoting interoperability, improvement activities become 30%, cost becomes 30%, and quality becomes 40%. And then if you were to take both the automatic reweight and the cost reweight, then it's a 50-50 split between improvement activities and quality. Now, what if you only want to do the cost reweight? Well, that's easy. So you would do IA of 30, PI of 30, quality of 40. Okay, so I'll stop talking here for a minute. And unfortunately, our polling isn't working right today. So go ahead and type your answer into the chat. What do you think you're going to take the automatic PI reweight? Is that something that you're interested in or want to learn some more about? And then with these increased thresholds, do you think you're going to perform okay for 2022? And again, to get to the chat, there should be a little chat box up at the top of your screen. It should look like a little bubble with some lines of text in there. And I'll pause here and let you type. Yeah, that's great, Allison. Like I said, I really don't encourage organizations to take that reweight. It's tempting, it's there. If you really must, you must. Maybe give yourselves a year to rejigger the way that you're doing your PI. But if you can do it, do it. It's good practice to be in. Perfect. Okay, we'll move right along here. Let's talk about the individual category changes. Okay, so buckle in. We got a lot to talk about. Now, in the past, new measures only provided 3 points automatically. And so because of that, fewer clinicians were picking those measures. While you can always pick more than the required 6, a lot of organizations were only submitting 6. And so when they saw that a new measure could only give them 3 points, they were being de-incentivized. And so CMS has seen it as a challenge to get clinicians using new measures instead of relying on some of the moldy oldie ones. So they're changing it. It's now worth 7 points for 2 years when a new measure is introduced. So if there's no benchmarking for it, it will earn you 7 points, which in some cases that might be higher than what you would earn on other measures. So that's something to look forward to. If you are struggling in your quality measures and you need some additional ones, try looking at some of these new measures, particularly if you have your base 6 that you really like, but you really want to choose your quality scores, look at those new measures. Now, previously you would get 3 points for for at least submitting complete data on any measure, didn't matter what it was. However, CMS is removing that floor. Instead, if you submit data, and even though it's complete, if it's a poor score, it's a poor score. You would get 1 point potentially. So, of course, this only applies to measures that are older than 2 years and aren't considered new. Now, if a measure does not have a benchmark, CMS will remove the 3-point floor and can make it worth it as little as 0 points. The exception to this would be small practices who would get 3 points. So these are existing measures that are older than 2 years that still don't have a benchmark. CMS is essentially killing those measures or de-incentivizing the use of those measures unless there's more data collected to receive those benchmarks. They're also changing the case minimum. Previously, there was a case minimum of, I want to say, 10 cases, there is now a 20 case minimum, so you need at least 20 eligible patients within a measure for it to be counted. So yeah, that minimum is going away or changing. And if you don't meet the minimums, you could still submit and get 3 points. Those 3 points go away as well. And finally, well, sorry, there's 2 more. In the last 2 years, if you submitted 2 or more high priority measures, you would get an extra 2 points per measure. That's going away. So there's no longer extra points for submitting high priority measures. A lot of practices would go through in a hunt for the high priority measures because they brought extra points. And you can still submit those. And in fact, you still have to submit some high priority measures, but there's no benefit for making all 6 of your measures or all 10 of your measures that you're submitting high priority. Instead, the incentive would be for you to hunt down and pick the measures that you are doing well in, or that you want that 7 automatic points. And finally, the end-to-end electronic reporting bonus is going away. So the submitting your quality measures electronically, which I think all of us were doing, that qualified for a 1 point bonus per measure. Unfortunately, that ends. And so starting in 2022, that will no longer matter. You will still get that for 2021's data. So even though you're submitting 2021 data in 2022, it'll be 2022 data that you're submitting in 2023, where you won't get those bonuses. Okay, so let's talk about the new quality measures. These are the 4 finalized of the 6. The 2 that didn't make it, the risk standardized acute unplanned cardiovascular related admission rates for patients with heart failure. CMS said they really like this measure. However, there was some issues in their beta testing of the measure, and they want to fine tune it. And then the other one, the COVID-19 vaccination by clinicians measure. Honestly, this one's kind of weird. When you read through it, and they said, CMS has chosen not to comment on the reasons for this measure, and that's it. All we know is they didn't adopt it. They didn't explain why. Now, there is 85 quality measures that have substantive changes, and some of them are pretty major. Go ahead and take a screenshot. The recording and this slide deck will be posted to our website too. The ones that are highlighted are the ones that we see most often used by our practices. And if you want to take a look and see what changed, the final rule, starting on page 897, table D of the final rule, starts off and it goes in numerical order, starting with 001 all the way through 478. And you can see what has changed and their reasonings behind the changes. So every one of these that are highlighted, these are very popular measures, and they have changed in one way or another. All of them are considered substantive changes, meaning that there may be more or fewer patients that are counted in the denominator. And some of the CQMs have been removed. They proposed 19 for removal. They ended up removing 16. The biggest one that they proposed was 317, which is preventative care and screening for high blood pressure and follow-up documented. They are changing it. And I'm going to go ahead and read these changes because I know this is a very popular measure, so bear with me. The description will be updated to replace pre-hypertensive with elevated. Additionally, the definition of the collection types will be revised to reflect the 2017 ACC AHA guidelines. So what this means is they are going to increase the population of patients that 317 applies for. So this could substantively change how you do this measure, meaning that instead of a more narrow niche, the pre-hypertensive folks, it's anybody with elevated high blood pressure or elevated blood pressure that will be eligible. So That's an important distinction. It follows the ACC guidelines for elevated blood pressure, so there may be more people that this applies to. Now let's switch gears and talk about the cost category. So there are 5 new measures. The data will be automatically collected through your claims data. So it'll be CMS who determines if this applies to you or not. There is nothing you can really do to directly affect these cost measures unless you have some kind of really great insight tool like a pop health tool. And even then, it's only as good as the data being fed to it. So if you're not getting data from a hospital or from other clinics and what they're submitting in their claims, then your data is still going to not be terribly insightful. Being a part of an IPA or a CIN that shares their data is another good way to do your pop health. Doing it on your own is really tough. Let's talk about promoting interoperability changes. So the public health and clinical data exchange, those become required now. Now, of course, like everything else, there's a bit of an asterisk. You can claim exclusions, and there's a detailed list of what exclusions would apply. It's particularly around those that aren't going to be dealing with those sort of things. So such as a gastrointestinal practice, you're not really going to be doing immunizations, so you don't need to report to that. You can claim an exclusion, and the electronic case reporting too. So that's going to be more pandemic-y type reporting. Now, if you do report to a public health registry, a clinical data registry, or a syndromic surveillance registry, you can get extra 5 points. Now, you can't claim 15 points by saying yes to all 3. It's just 5 points regardless of any combination thereof. So if you already have one of these registries, great, you'll get an extra 5 points, and that's promoting interoperability points, not your total points. But that can help boost your PI score. But yeah, the maximum number of points you can hit here is 5. So I think many organizations already report to some sort of clinical data registry. So you can claim an extra 5 points this coming year. Another one was that was proposed was the provide patient electronic access to their health information measure. Boy, that's a mouthful. Essentially, it was going to require that you provide indefinite patient portal access to your patients. This was not finalized. They said, however, that this is something they are very interested in doing, but the feedback was that the systems that currently exist for patient portals, as well as storage requirements, still aren't there yet. That it needs a couple more years to mature till we get to that point where patient portals are better, and that storing is not onerous. Storing of records is not onerous, but essentially they're saying all of those, HIPAA compliance, 7 years of data doesn't matter. Instead, it should be however far back as you can go with their health information. So that's something to consider if you are regularly purging your data. After 7 years, you're putting it in an archive, or you're tossing it away. Whatever it is that you choose to do that's compliant to HIPAA, that may not matter anymore. And CMS did say that this kind of flies in the face of HIPAA. So there may be some changes coming to HIPAA that are going to require that practices keep their data indefinitely, and then we could see this measure reintroduced. There's a lot of talk in there. If you want to go and read through what they had to say about this, you can. It's in the final rule. It makes for an interesting read. They are introducing a new measure, the SAFER Guides, which is the Safety Assurance Factors for EHR Resilient Guides. It's an annual assessment that you need to attest to. Information about SAFER can be found online, and in the final rule, they have some references there where you can go to read up on SAFER guides. That's probably another conversation or another webinar for another day. But if you have some questions about that, please feel free to drop me a line. And then they are modifying the prevention of information blocking. They are aligning with other government guidelines and initiatives that have been issued, essentially just really reaffirming the fact that, no, you need to be sharing your records. You can't hoard them and keep them secret. They are making changes to promoting our improvement activities. They are changing, they're giving themselves the authority to change an improvement activity or stop an improvement activity in the middle of the year if they have been deemed to cause harm. And they're also issuing new guidelines for how to create new improvement activities. Speaking of improvement activities, there are 7 new ones. I'll pause here if you want to take a screenshot. There's some good ones here. There's a highly weighted one there. Number 1 and number 2 are both highly weighted. All the others are medium weights. The highly, there's a typo there. Number 2 should be highly weighted as well. And so what these are really about is looking at other aspects of healthcare beyond the clinic. And then they have changed 15 of the improvement activities. So if you are doing one of these improvement activities, be sure to take a look and see what the changes are. Okay, so we'll pause here, give me a chance to sip some water, and feel free to answer in the chat. What measure or activity change are of greater interest to your organization? And I promise here, folks, we'll be wrapping up. I know we probably have some questions, but we'll be diving deep into the changes coming to MIPS here in just a moment. Okay, Allison. Yeah, it is really hard to tell, and I know it's drinking from a fire hose. You really haven't had a chance to look at everything quite yet, but I would personally say for most organizations, the biggest and the most substantive changes are going to be those quality measures that are changing. It's going to increase the population that applies to the measures, and so it may make some of those measures harder for you to achieve. Okay, so let's talk about MVPs. Is this the beginning of the end of MIPS? And yeah, actually kind of. So MIPS or MIPS value pathways, or MVPs as they call them, because having an initialism inside an initialism makes sense, right? You know, the M in MVP stands for MIPS, whatever. That's the government for you. So essentially what CMS was trying to do was streamline the MIPS experience for clinicians. They stated that their goal of the MVPs was merely a way to help clinicians take the guesswork out of how they can or should participate in MIPS and ultimately QPP. I talked about MIPS value pathways last year. It was met with a lot of skepticism. There's a lot of questions around it. What does it mean? CMS said that in 2021 they'd be issuing more guidance. Guess what? They didn't. Instead, they saved it for the final rule for this year. Now, ultimately, everybody that is in MIPS today will end in an MVP in one fashion or another. So here's their proposed timeline, and it's still considered proposed, even though the final rule really firmed it up. All their documentation is still saying proposed, and I guess it's because they are anticipating it changing and being a little more flexible than quote unquote final timelines will be. The goal of this will be to end traditional MIPS. So MIPS, as you probably submit it today, you'll be forced into the MVP program come 2028. So just about 6 years from now, MIPS as you know it will be done. So what is MVPs? Well, it's a pre-assembled list of quality measures, improvement activities, and cost measures, which are partially based on what we call the quality specialty measure sets that CMS has curated since the beginning of MIPS. The quality specialty measure sets, those are essentially, if you've ever been on the QPP website, you can go to the catalog of measures and you can say, okay, I'm a cardiologist, and it will pre-filter out all the measures and leave you with, like 15 measures that they think might be good for your specialty type. They're not required that you do that. You can right now pick any of the 200 some odd measures and you can report those regardless of what your specialty is. CMS feels like that is overwhelming for a lot of practices, particularly the smaller practices that may not know that. So they are starting with a much smaller group of MVPs. The first 7 will be rheumatology, stroke care and prevention, heart disease, chronic disease management, emergency medicine, lower extremity joint repair, and anesthesia. So these are the first ones that they're starting with, and you can get an idea in the final rule on what measures are going to be in those 7 MVPs. Now, an MVP will have that very small menu of the pre-selected quality measures, in which they will get to pick 4. So instead of having 15, it'll be an even smaller menu. It'll be like 6 or 8. And then an MVP participant only needs to pick 4 quality measures. That's 2 fewer than what they have to pick today. There will also be a limited menu of improvement activities. Same sort of thing is CMS will look at what that particular MVP's field of medicine is, and then narrow down the list of improvement activities that could probably apply to them. Now, if you don't want to do improvement activities, maybe you participate in a patient-centered medical home, a PCMH, that will automatically fulfill your improvement activities. CMS will also pick the cost measures, which again, you don't really have a whole lot of control over that. It's kind of that way today too. And then there will be a population health measure. Now, a population health measure is either going to be an improvement activity or a quality measure, and you'll have to do one of those. And again, same sort of deal, it'll be a very shortened list. And if for example, you are part of a PCMH and your population health measure that you decide you want to do is an improvement activity, you would have to do that improvement activity. The PCMH would not cover that population health measure. And then you would still need to do your promoting interoperability. So the PI would not go away, and I would anticipate that by then the small practice exemption would also go away. Now, how it'll work is clinicians will register for an MVP between November 1st and November 30th, or sorry, April 1st and November 30th of the performance year that you're in. This will be some extra steps that will be required. This is, they don't have a portal open yet, and since come 2023 is when they're going to start enrolling people, I don't anticipate seeing it for another 18 months. Now, if you participate in CAPS, your deadline will actually be June 30th instead of November 30th. Clinics that have multiple specialties, so a cardiology clinic that has maybe a cardiothoracic surgeon and an electrophysiologist, they may not be applicable. Your MVP for your whole group may not be applicable to your subspecialists. So they may have to create a subgroup. So there's information about that in the final rule, where a organization may have 3 or 4 MVPs that they have to do, and the clinicians are going to be deemed eligible for certain MVPs based off of their taxonomy code and what sort of information is submitted in claims data. It'll be in this portal that you will select your 4 measures, where you'll pick your population health measure, any improvement activities, and that sort of thing. And then each of the clinicians within the MVP will be judged against other clinicians in identical MVPs. So you won't be judged as a whole, as your whole clinic. It'll be each of the MVP groups and subgroups that will be judged, and they'll be judged against matching MVPs across the nation. Okay, I know that's a bit of a fire hose of data, but that should give you some idea of how MVPs are going to work. Right now they'll be voluntary, and then eventually they'll be mandatory. And over time, as we see them get turned on and each rule that they issue every year between now and 2028 will increase the amount of MVPs that you'll be able to participate in. There does not appear at this point in time to be a point or monetary incentive to participate early, but they did not dismiss that idea. In fact, they said in there that CMS is looking at methods of encouraging early adoption. So stay tuned for that. I suspect next year's final rule will clarify that, and we may see some form of incentive payment or maybe an increase or one-time payment to get you to participate in MVP a little bit early, because there's some risk involved with that, as we know. Okay, final question. So, and again, this is one of those little questions. You don't really have all the information. So I guess really the more the question is would you be open to participating in an MVP if one was made applicable to your organization before it's mandatory? So if there was, I don't know, if you're a GI group and there's a GI MVP, remember it means fewer quality measures, it means a more curated list. Okay, Allison. Allison's open to it. Yeah, great. Thank you, Allison. Yeah, I am really curious about these MVPs. It seems to me that once you opt in, you may have the opportunity to opt out too. CMS did not say that that wasn't going to be allowed. That question was asked very specifically. So maybe if in 1 year you opt in, you voluntarily do it, you're like, this isn't for me, wait for them to fine tune it, you may be able to opt out. CMS didn't say yes, they didn't say no. I think they're waiting to see what it looks like too. Okay, so let's talk about our next steps. Well, read the final rule. I'm going to be posting a link, not in our chat, but on our website later today when I upload the recording and the slide deck. So read the final rule changes sheet. It'll be there. I'll also be uploading the full final rule or link to that. This is where the new quality measures are found. They're found on page 692. All the changes are found on page 897. And improvement activities, 974 for new ones and 984 for the changes. There are, unfortunately, and kind of strangely enough in the final rule, there aren't any good places to find the changes to the quality, to the cost measures. They're there, but they're not in any one place. They're just kind of talked about loosely throughout it. So it's really hard for me to pinpoint and say, okay, the changes are X. And honestly, that being said, cost is so opaque to all of us on this call that it probably really wouldn't be worth your time to read through what those changes are. Okay, so the official resources link, you can go to qpp.cms.gov, click on the resource library, or go directly to the link there. You can also call the QPP help desk. When I have a question about QPP, this is who I call. They are very helpful and very knowledgeable. Alrighty, so if you have questions and you want to ask your question, we can unmute you, just raise your hand. Otherwise, you can drop it in the chat. And if you don't have any questions or you're so overwhelmed, you need to go think about it a little bit, that's fine. You can drop me a line. My email address is ahiggins@shpllc.com. Be more than happy to help you out. And like I said, the recording and all the resources will be posted on our website, hopefully later today at shp.com/webinars. Alrighty, I'm going to hand it back to Jason, and Jason can take us home.
Awesome. Thanks a ton, Aaron. Lots of information as usual. And as he mentioned, please, there's so much within this ruling. If you have any questions, you know where to find us. Please do not hesitate to reach out, and we'll do our best to answer any questions or concerns. Or obviously, as you see, any of the other services that we can be of any assistance to provide, please reach out to us. As Aaron mentioned before, we will shoot later today or tomorrow to have the recording and presentation uploaded. And as you probably saw initially through an e-blast, we've got a series of webinars scheduled over the next 3 months. Our next one will be next Wednesday, I believe, the 22nd, regarding the state of managed care. So please be on the lookout for it. Going forward, we will be using Teams as you did today and as we've done previously, and just feel free to register accordingly. And with that, we appreciate your time. Hope you have a great rest of the day and the rest of the week. Thanks, everybody.
Have a great afternoon, everyone.